Hello, I'm Melissa Cardine, and this is Jennifer Whalen, and we're
Hello.
from the Bridge Health Advocates. And we are presenting number 4 series for our CMS Health Equity Physician Fee Schedule changes for 2024. So welcome to our presentation.
Thanks everyone for popping on to watch this. I just will review the 4 parts of the health equity changes by CMS. So there's caregiver training services, social determinants of health risk assessment, the community health integration, and principal illness navigation. So in our last 2 videos, we went in depth on community health integration and principal illness navigation. This time, we're also going to touch on social determinants of health risk assessment. We have not addressed the caregiver training services, but if that's something that you guys are interested in, let us know, or if someone has experience with that, we'd love to hear from you. All right, so we've got a case scenario that Melissa is going to talk about. So we'll use this case scenario to kind of interweave 3 of those 4 components of the health equity issues for CMS.
Yeah, so we have a 66-year-old male. He lives alone and he was newly diagnosed with prostate cancer. And he saw his physician, his providers. He's scheduled for chemotherapy and then surgery. As far as his insurance goes, he does have Medicare Part A and B. And it has been recognized that at this time, he's not able to drive. So that's a little bit concerning. Like, how is he going to get to all of his appointments? He's very tired and short of breath, which, as you can imagine, this makes it just really hard just to take care of yourself. Especially with the diagnosis of the prostate cancer. He does, as far as buying his food, he goes down to the local convenience store, walks there right now, but he's having a difficult time getting there. And as we all know, that is a little bit concerning that that's how he's getting his nourishment. And it also has been identified that he might possibly have some mold in the home, which is also of some big concern. As far as his support system goes, his daughter lives out of state and really isn't involved in any of his care. And so after seeing his provider, it was recommended that he schedule an appointment with a pulmonologist, and he just wasn't able to follow through with that.
All right, perfect. Okay, so thinking about the case scenario, just keeping that in mind, here are the 3 items that we will use today to help this patient out. So one is the community health integration. So you have to make sure the patient has these social determinants of health needs that significantly limit the practitioner's ability to diagnose or treat the problem. And the patient can't be under a home health plan of care already. Which it seems like this patient is not. Principal illness navigation, he has to have serious high-risk condition that's expected to last 3 months or longer. We have that with his prostate cancer diagnosis. He has significant risk of hospitalization, nursing home placement, acute exacerbation, functional decline, or death. Absolutely, he does have a risk of hospitalization going through treatment for cancer. He requires a disease-specific care plan, so that is something that his oncologist or primary care physician, whoever it might be, will absolutely have put in place. And his disease, it may require frequent adjustment of medication or treatment regimen or substantial assistance from caregiver. Absolutely, on all of those fronts, his diagnosis and his situation checks those boxes. So the social determinants of health risk assessment, that you have to have 1 or more known suspected social determinants of health needs that may interfere with diagnosis or treatment. So you can see from this patient's background, situation, residence, that there are possible issues that could interfere with diagnosis or treatment: transportation, food, social support, those types of things. So in that risk assessment, it must address 4 items. So food insecurity, housing insecurity, transportation needs, and utility difficulties. So difficulties heating, cooling your home, water supply, those types of things. So Melissa talked about this a little bit, but do you think this patient's appropriate for any of these services?
Yes. So
Yeah.
when we look at this gentleman, we have to sort of look at his insurance, right? So he does have Medicare Part B, and these services are covered under Medicare Part B. He has providers, right, who identified through this risk assessment
Mhm.
that yes, he is at risk for, you know, with this diagnosis. So then, therefore, he qualifies for community health services, and also that principal illness navigation, which is that serious high risk condition, which is the prostate cancer.
Yep.
So he definitely qualifies, and this is a perfect scenario, right, to implement these services utilizing his Medicare Part B benefits.
Absolutely. Okay, so a little bit about the social determinants of health risk assessment. There are several different tools that CMS has approved, and there are others that you could use. Like I said before, it just has to assess for those 4 items. They are completed by the patient generally at an evaluation and management visit, or it could be at an annual wellness exam. It can be at other visits, but this was done at an evaluation and management visit by the oncologist. So it's usually a couple page, paper that the client, the patient, if they're able, they can fill out. And then the billing practitioner, in this case, the oncologist, will assess that and say, oh, yes, there are some, needs that we have here. So this is just an example. It's the prepare tool. So it's the protocol for responding to and assessing patients' assets, risks, and experiences. So all of those things, it's housing, it's social support, it's food, it's those types of issues that we are looking at. So Melissa, do you think that, do the social factors influence the diagnosis and treatment of, medical conditions? For
Absolutely. And
yeah.
one thing is, when I saw this risk assessment, I also want to know who's actually filling it out. So is this assessment, is a piece of paper or is a tablet, given to, let's just say, this gentleman, right? Who, if he would fill this out himself without maybe asking a little bit more detail, he himself might think it's perfectly fine. He's getting the nourishment he needs, right? He doesn't have an issue with getting to appointments that so I would want to know who's actually filling this out, and hopefully this gentleman has somebody who's can help him make sure that he's filling it out accurately. So that could easily be done by the provider's office, maybe asking the questions like, can you tell me more about, where do you get your meals? Who prepares your meals? What do you eat in a typical day? Which then can identify, actually, we do have a concern here with how he is getting food. So when I first saw this risk assessment, and I think this is just something we all just need to be aware of, right? Is when, whether it's as an advocate, it's somebody we're going to with an appointment, or if it's a loved one, is who actually filled it out and did they fully understand the questions being asked? Because we know that pride can, take a role in sometimes, and sometimes people are like, I'm fine. I have a place to live. I have food. I'm okay. But definitely with this gentleman, we know that there's, transportation issues. We need to make sure that, especially as he, moves on in his treatment plan and he gets even more fatigued, that he can get to his actual appointments, and that we know nutrition is just vital when you're treating cancer, that he is going to be able to get the nutrition he needs, especially if he's nauseated and vomiting and things like that. Um, and this is just a perfect example of identifying these needs and, implementing somebody to assist and make sure as he goes through this process with this diagnosis that he's getting the support he needs.
Mhm. Yeah, I agree with you. Such a good point on that. I see these sheets and I'm like, oh, this is a little overwhelming, all the boxes and what am I putting here? And hopefully the providers do have assistance with this. You know, if they notice things aren't filled out completely, they're asking more questions and going a little bit deeper. So the billing practitioner can bill, you know, for this time. The reimbursement is about $19 for doing the social determinants of health risk assessment. And you can do the assessment every 6 months. So just some technical aspects of completing this for providers. All right, so let's look at community health integration. So the assessment was done, billed by the practitioner. They say, yep, there are some social needs that are influencing diagnosis and treatment. And so she's going to order community health integration services. And so that is not, you know, those services don't need to be done by, you know, the oncologist. There's someone in their office or remotely, which their CMS is calling auxiliary personnel. They're going to meet with the patient, you know, to discuss needs and help understand the patient's situation better. And so CMS talks about, you know, actually finding out what the lived story is of the patients, what's really going on in their life that's influencing, you know, their medical conditions and their ability to seek treatment and to heal. So I love that they, you know, are making that commitment. So in this case, I would say, you know, these are the, you know, issues that they're going to address right away. So transportation, food, maybe even supporting some communication with the daughter if that's what the patient desires, because they are going to need some social support. Maybe it's not the daughter, maybe it's a friend or, you know, other people, but if that's what the patient desires, then helping facilitate that. And getting an assessment for mold. Is there mold in the home? Is that contributing to the shortness of breath? Is, you know, what do we need to do there? Is it an unsafe situation, or do we just need to get some, you know, some cleaners in there, whatever it may be. So just also a reminder that community health integration addresses person-centered planning, health system navigation, facilitating access to community-based resources. I mean, there are so many resources out there from all types of organizations, nonprofit organizations, the state, religious organizations, all, you know, who have all kinds of things that people just don't know about until they're in that situation. And so these community health workers are just, you know, absolutely wonderful at identifying those resources and sharing them with the people who need them. Practitioner home and community-based care coordination and patient self-advocacy promotion. So helping the patient realize, you know, giving them education. This is what you do. This is how you do it when you need to make appointments or when you need to call for transportation or whatever it is, so that in the future they are able to do those things. Okay, so moving on. So the oncologist, after seeing this patient, is noticing that the patient does need a little more support and education regarding the cancer diagnosis. So she's going to initiate PIN services as well for prostate cancer. So in order to receive PIN, the patient must have one serious high-risk condition. So we've got that with the prostate cancer. For a PIN peer support, remember it has to be a behavioral health condition. And so those conditions are expected to last 3 months. They place the patient at high risk of hospitalization, nursing home placement, acute exacerbation or decompensation, functional decline, or death. And that condition, it's a condition that requires development, monitoring, revision of a disease-specific care plan. They may require frequent adjustment in medication or treatment and substantial assistance from the caregiver. And that may happen in the future, you know, with this patient as well. So, is it okay to bill for CHI, the community health integration, and PIN at the same time, services at the same time, Melissa?
Yes.
That might
Yeah,
be something.
so this oncologist absolutely can, as long as there's no duplication of services. So
Yeah.
let's just take the example of transportation. Maybe it might fall under this principal illness navigation because there's an acute need to get him to these appointments and the treatment. We're addressing the food, nutrition, the social aspects of, the relationship with the daughter, that will probably fall under community health integration. So as long as there's no duplication, they both can be implemented at the same time.
Perfect. Okay, so what are some things, as we're talking about this, that the navigator can do that does not overlap with CHI services? So where's the gap here that the community health integration wasn't addressing? So maybe they're going to help meld the practitioner plans with the patient goals, right? They can really sit down with the patient and say, give them education about their new diagnosis, what possibly will be occurring in the future, what are your goals, for this treatment, and then helping that, coordinate, come together with what the medical practitioner has for them. Also coordinating appointments for testing and treatment of their cancer, arranging for durable medical equipment for the patient if needed, providing that cancer-specific education, maybe even doing some education on possible clinical trials as needed. So there are lots of things that the navigator can do outside of the CHI services.
Yep.
Okay, so let's take a look at this. We've got a scenario update for our client. So the patient's daughter, so apparently there's now been some communication between the patient and his daughter, and she has gotten to speak with the navigator, and she says, I really want to help more, right? So these are the things that she wants. She wants someone to see her father in his home. I actually put that twice. I think it's so important. So she wants to see someone to see her father in his home, see what's going on there. She doesn't live in the area. She lives out of state. Is there someone who can be her eyes and ears? She wants one person to communicate with her about his appointments and medical updates. She's kind of had a hard time, talking to the nurse at the oncologist's office, and then pulmonologist, and then a primary care, and they're all different providers that he has been seeing. And she just thinks it would be smoother, better if there was one point person. She wants someone who can make sure he's safe when he goes to the hospital, and that things aren't getting missed between the hospital and his home. And so the PIN is suggesting, an independent patient advocate. So that's kind of where our role comes in. So does this sound like something that an independent patient advocate can do?
Yes. So what it looks like is, you have a loved one. In this case, it's a daughter, right? Who she now wants to be involved in her father's care, but she lives out of state. So that makes it very, very difficult for her to be actively involved. She can support him over the phone, email, texting, but not be able to be there in person. And so we're identifying who could be that one person to this gentleman. And he doesn't have anybody else. So he doesn't have any other loved one, neighbor, friend who could fulfill that role of really stepping in. And it's not only the support, but that one person who manages everything sort of going on and making sure that, the providers have all the information that they need during the course of his treatments, along with that he's understanding everything that's going on with his treatment plan. So this is an ideal situation for a patient advocate. Most likely in this scenario, the daughter may say, you know what, I would like to do this for my father. This is something that I will pay for my father. And, as long as he's on board and he's like, you know what, which this might be a little bit hard. He's a young gentleman. He might think he's fine and he doesn't need help. But after talking with him, a patient advocate can talk with him and explain how, you know what, we're still letting him do as much as he can. But we do know that with this diagnosis and treatment plan, there are going to be days where he just can't stay on top of everything. And you would be that one person he could lean on and go, you know what? Can you make sure I could get to my appointment, or I'm needing assistance with this? And so that's where the patient advocate could step in and support him and the daughter, along with all the providers, along with the community healthcare worker, along with whoever's identified as that PIN person in the oncology office. So that might actually be a nurse navigator, right? So that advocate is going to work with everyone. So, Jen, do you have any insight? Nope.
Yes, sorry, I've clicked to the last
No,
screen.
you're fine.
So I just think, you know, it doesn't take someone very long to realize how disjointed this healthcare system is when they have, you know, a family member, they have a serious, you know, medical condition, and she just rightly gets to it. She's like, I need something else. You know, you guys are all helpful and great, but you know, I need a little bit more. And I can see the advocate, you know, he might need a caregiver in the home at some time. So maybe the advocate is then, you know, getting some companies on board for, you know, whoever can help with that. So how does the advocate continue to work with the navigator and CHI, Melissa? Like, is this
Yeah.
something that the advocate gets on board and then they don't need the navigator anymore, the community health worker? How do
No.
you think?
No, so I mean, a lot of times as an advocate, so personally as an advocate, right? Um, a lot of times this is on a portal, even a patient's portal, you'll see that it's identified this person, you know, is the community healthcare worker with them. This is the, you know, nurse navigator. So it's part of our role is to introduce ourselves to them and what our role is, and also go, okay, so what is it that you have identified as concerns and what are you working on? Again, we don't want duplication of services, and we don't want to be, you know, at one another, right? We're like, okay, this is, you know, what they're providing, and maybe they're like, oh, well, I'm working on this aspect of the whole molds thing, which could be a whole project in itself. You might have tidbits of information to provide to them. Like, you know what? Actually, when I was in the home, you could visibly see mold. Or I'm concerned because when I go in the home, you know, you can tell that there's been water damage, or, you know, the plumbing hasn't been updated for 30 years and there could be a leak right behind a shower, a toilet, a vanity, which is insight you could bring to them maybe as they're seeking out, well, how are we even going to do this? What type, you know, who do we need to send to the home? So it really starts out with an introduction of what your role is, learning more about their role, what they're looking at, and then sharing information with them. Again, not duplicating services. But that's really what it sort of looks like. But yeah, you definitely work with them.
Yeah, absolutely. I mean, it just sounds like independent patient advocates, we really want to be as efficient as possible for our client. You know, if there's someone that we can utilize within the healthcare system to help out their situation at all, of course, we're going to do that. I mean, we need to know all of our resources so that we can provide, you know, the best advocacy that we can for our clients. So I'm going to stop our share and we're just going to chat for a little bit
Sure.
longer, kind of a final, you know, wrap up. So this has been eye-opening for me as we've gone through all of the information from
Yeah.
CMS relating to health equity, which has really, you know, been important. I do want to remind everyone that there are other services through CMS that could come into play here that, you know, practitioners have been billing, you know, for a long time. So there's principal care management. So that's similar to the PIN services. But those services are really provided by clinical staff. So maybe some nurses or others, and they are addressing a somewhat higher acuity of disease. So that can come into play also. There's also chronic care management with 2 or more chronic illnesses that are lasting, you know, 12 months or longer. There's complex chronic care management, transitional care management for patients who have recently been hospitalized and are being discharged from the hospital. So all of these are things that providers can take advantage of when they're providing those services. So let's talk a little bit about what we've learned throughout all of this. So where do you think this leaves, the health equity changes to the physician fee schedule? Where do you think that leaves patient advocates and our clients, Melissa?
I think it's in a really good place. I really do, because it's starting to fill those gaps that we have known about, we've seen, and really just until honestly Medicare sort of steps in and leads the way, we're not going to see other, insurances. So let's remember, not everybody's on Medicare Part A and B, right? So we also have people on Medicare Advantage plans, right? So if
Mhm.
they are, you want to know, like, well, what do they cover? Are they covering these services? We have, people on employee health care, right? So are we seeing them sort of follow suit that, somebody's identified, high risk, are they implementing? We have a pediatric population, right? That has similar kinds of things that can happen. So it's just being aware that, these exist and asking questions to providers and or insurance, right? Do you cover any type of services, for unmet social determinants of health? Because these have been identified. They may say, you know what, actually we do. We have this program, and it may look similar to this, but it may be a little bit different. So it's really when Medicare sort of sets that standard for other insurance companies, other types of care. Even when we look at state funded care, we see the same thing. We talked a little bit about that, right, with community healthcare workers, that, it might fall under some state funded insurance. So it really is a great starting point. Actually been in effect, right, for these changes 2024, but slowly coming. Um, and so it's exciting as far as, personally as an advocate, when I, work with a client and I look at them at their portal with them and I see like, oh my gosh, you already have a care manager, right? I will say sometimes I get that message though, oh, I already have a care manager from my doctor's office, and I'm like, well, how do you differentiate? Or the insurance case manager is calling, how do we differentiate? The more we understand everyone's roles, the more you can have these discussions with clients and consumers that are like, hey, have you, you don't want to say take advantage of, but have they assisted you with these things?
Yeah.
No. Well, have you let them know that you're having issues with getting to your appointments?
Right.
Well, no.
They don't
Okay.
know because
They
patients don't
don't
know
know.
what they can do, what,
Right.
yeah, they can
Yeah.
get with.
Yeah.
Mhm.
So
Yeah.
to me, it's really exciting.
Yeah, it's such a good point about CMS. I mean, they do put these things into place, and it does drive the rest of, the healthcare industry. And because one thing is they're going to collect the data on it. So they're going
Yep.
to be able to say, oh yeah, we had this many providers doing this social determinants of health risk assessment, and then these outcomes were different for these better, hopefully improved, for these patients. And I think that's really important because if they're showing decreased hospitalizations or improvement with whatever, or, utilizing fewer services within the healthcare system, that's great. And then what insurance company wouldn't want to take advantage of
Yeah.
that, right? Because it's going to be cheaper for them in the long run and just better for patients. So if you can hit all of those, buttons, I think it's really important. But it starts with the data saying,
hmm
listen, we're doing this,
Absolutely
and
right.
it works, and look at these numbers. Um, so I kind of am just, thinking that it really is going to start creating this durable workforce. And I've said that before, but just where we're going to have people who are going to be trained, who are going to be, going into this as community health workers. We already have it in the States and it's great, but it just lends itself to, more people being trained and more people utilizing those services. And I think that's really important. And I'm just really optimistic about this. And hopefully, as long as it's on the radar of patient advocates and patients and providers everywhere, I think it's going to be a good thing for all of us.
Yeah. So, a little bit, Jen, what else do we have coming up after this 4-part series that we just
Yeah.
completed?
So we're just enjoying doing this format and like getting our videos out on YouTube, and people can start now listening to them, as a podcast, and hopefully it brings some, information to you, knowledge that you didn't otherwise have. The next one that we're going to do is HIPAA, actually. So HIPAA and patient advocacy. So I have a lot to say about HIPAA. I've done a lot of research on this, and I just want to share how independent advocates can utilize HIPAA for their clients. And then also, like, are they subject to HIPAA regulations? How do they need to act within this world of protected health information in supporting confidentiality for their clients? So I think I have a lot to say about that. We'll do maybe a two-part series on that. And it's just, we get asked this all the time with our new advocates and HIPAA. So we're just going to put it out there, and hopefully everyone can benefit from that. So thanks everyone for joining us, and we will see you later with some
Yep.
new good information.
Yep. Thank you, everyone.
Thanks.